Hello everyone. Today let us discuss about systematic interpretation of intraoral periapical radiograph. Welcome you all to Oral Medicine and Radiology Made Easy. Interpretation of radiographs can be regarded as an unraveling process, that is, uncovering all the information contained within the black, white and grey radiographic images. Is interpretation and diagnosis are the same? No. Interpretation refers to an explanation of what is viewed on a dental image, whereas diagnosis refers to the identification of a disease by examination or analysis. So, interpretation is what we see on a radiograph and diagnosis is identification of a disease by interpreting the radiograph. Why do we need to interpret the radiograph systematically? A systematic approach to viewing the radiographs is necessary to ensure that no relevant information is missed. The main objectives are to identify the presence or absence of disease, to provide information on the nature and extent of disease, and to enable the formation of differential diagnosis. So, radiographs should be viewed on a view box which has equal intensity of light. If necessary, use additional intense light. And also, it's better to use a magnifying glass to interpret IOPA radiograph. Pathology in the radiograph should be described in terms of radiolucency and radio opacity. And in the object of interest, start interpreting from the coronal portion and then go to the radicular portion. Also, look at the other findings that are seen in the radiograph, make a radiographic diagnosis and then a radiographic differential diagnosis. So, first we have to identify what type of radiograph it is, and once we have identified it as IOPA radiograph, we have to identify which arch it belongs to, whether it's maxillary or mandibular. Then we have to identify the side, that is right side or left side, and then mount it in the anatomic position. So, how do we mount the radiograph? We all know that there is a dot on one corner of the film. It has a convexity on one side and concavity on the other side. And convexity is the side that is always towards the tube. So, there are basically two types of mounting method. One is labial mounting method, the other is lingual mounting method. In the labial mounting method, the radiographs are viewed as if the dental radiographer were looking directly at the patient. That is, in the labial mounting method, the convexity is towards the radiographer and radiographer is looking at the radiograph as if he is standing in front of the patient's mouth. That is, the radiographer's right is patient's left and radiographer's left is patient's right. So, we have to imagine ourselves to be standing outside the patient's mouth whenever we are using labial mounting method. And in the lingual mounting method, the radiographs are viewed as if the dental radiographer is inside the patient's mouth and is looking out. So, in this method, the concavity is towards the radiographer, and when the concavity is towards the radiographer, he has to imagine himself to be standing inside the patient's mouth at the place of the tongue, and the entire set of patient's teeth are around him. So, here the radiographer's left is patient's left, radiographer's right is patient's right. Let us see once again. Suppose we are mounting the radiographs in labial mounting method. We have to place the radiographs with the convexity towards us, and we have to imagine that we are standing outside the patient's mouth in front of the patient. And when the concavity is towards us, as in lingual mounting method, we have to imagine ourselves to be standing inside the patient's mouth at the place of the tongue with the entire set of teeth around us. I hope now it's clear on labial and lingual mounting method. General overview of the entire radiograph. First, we have to note down the details of the patient when we start interpretation. We have to identify the type of the radiograph, which all teeth are seen, and identify the normal anatomic landmarks. A detailed knowledge of radiographic appearance of normal anatomic structure is necessary. The normal anatomic landmarks help us to identify whether it is a maxillary radiograph or a mandibular radiograph. Also check if the anatomic landmark and their adjacent region are normal. In addition to the anatomic landmarks, it is the bone marrow and the trabeculae that help us to identify whether the radiographs belong to maxilla or mandible. There is difference in the trabecular pattern of maxilla and mandible. In the maxilla, trabeculae are thin and numerous with a fine granular dense pattern. The marrow spaces are very small here and are relatively numerous. So, the number of trabeculae are thin and numerous and the marrow spaces are small and numerous in maxilla. Whereas in the mandible, trabeculae are thicker and they have a coarser pattern. So, here the trabeculae are thicker, they are fewer in number and are oriented more horizontally. Here you can see they are oriented more horizontally and marrow spaces are larger. So, in the mandible they have fewer trabeculae and fewer trabecular spaces, but the marrow spaces are larger when compared to the maxilla. This is how we can identify whether the radiograph belongs to maxilla or mandible based on the trabecular pattern. Also, looking at the tooth morphology, we can identify whether the tooth belongs to maxilla or mandible. Here are some of the anatomic landmarks that are visible in IOPA radiograph. So, once we have identified the landmark and we have mounted the radiograph, let us examine each tooth on the radiograph and assess the crown, roots, apical tissues and periodontal tissues. So, in the crown, trace the outline of the edge of the enamel cap. So, first we have to trace the outline of the edge of the enamel cap. Next, trace the outline of the enamel dentine junction. Note any alteration in the shape. Possible cavitation caused by caries. So, when we trace the outline of enamel and enamel dentine junction, if there is any alteration in the shape, it is indicative of cavitation. Note any alteration in the interproximal enamel density. Maybe triangular shadows caused by caries. So, in the interproximal region also check if there is any alteration in the density caused by caries. Note alteration in the density of the dentine. So, once we are done with the enamel, check for any alteration in the density of the dentine, maybe the radiolucent shadows of proximal caries or occlusal caries. Note the presence and state of existing restorations. It is not just the cavitation, sometimes there may be radio opacity suggestive of restoration, and whenever such a restoration is present, see if they are over contoured, under contoured, overhanging, or if there is any adjacent recurrent caries next to the restoration. Trace the outline and shape of the pulp chamber. Note the size of the pulp chamber, presence of secondary dentine and presence of small radio opacity suggestive of pulp stones, and also look for the radiolucent line between two fragments of the teeth suggestive of fracture. So, here some of the changes that can be seen in the crown. As we trace the outline of the enamel, we can see there is alteration in the density or the radiolucency that is extending till the pulpal region suggestive of caries. Here radio opacity which is more than that of the enamel suggestive of restoration, and here we can see there is a restoration as well as a fragment of the tooth that is fractured, and here there is loss of crown structure because of the caries. The radio opacity within the pulp chamber suggestive of pulp stone. A radiolucent line between the two fragments suggestive of fracture, complete obliteration of the pulp chamber because of the formation of secondary dentin. These are some of the changes that can be seen in the crown of a radiograph. Next, let us interpret the root region. Trace the outline of the neck and cervical 1/3 of the root of the tooth. So, here we have to trace the outline and note any alteration in the outline, possible cavitation caused by root caries. Note any alteration in the density of the root dentin. Next, note down the length of the root, whether it has the adequate length, how many roots are present, their morphology and size and shape of the canal. Next, check for the presence of pulp stones within the pulp canal, root filling as you see in endodontically treated teeth, internal resorption, external resorption and root fracture, a radiolucent line between the fragments suggestive of fracture. Here are some of the examples that can be seen while interpreting the root region. A radio opacity along the pulp canal suggestive of a root canal treated tooth, radiolucency with irregular border near the apex of the root suggestive of external resorption, complete obliteration of the pulp canal suggestive of calcified canal, widening of the canal at one particular place suggestive of internal resorption, radiolucent line between the two fragments suggestive of fracture. Again, radio opacity in the pulp canal suggestive of pulp stones. After interpreting crown and root, next is the most important part of this radiograph, that is periapical region. So, check the integrity, continuity and thickness of the radiolucent line of the periodontal ligament space and the radio-opaque line of lamina dura, and also any associated radiolucent areas which may be because of periapical abscess, periapical granuloma or periapical cyst. Also, associated radio-opaque areas may be because of condensing osteitis or any other different lesions. Also, check for the pattern of trabecular bone. So, here we can see a normal periapical radiograph with a thin radio-opaque line along the root suggestive of lamina dura and a radiolucent area between the lamina dura and the root suggestive of the PDL space. Here we can see there is loss of lamina dura with a radiolucency suggestive of abscess, and here also we can see there is loss of lamina dura with the radiolucency. Here also we can appreciate there is widening of the PDL space. Here you can see radiolucency with a thin sclerotic radio-opaque border suggestive of a cyst, and here you can see radio-opacity suggestive of condensing osteitis. Next, we have to interpret the interdental tissues or the periodontal tissues. So, S is the width of the periodontal ligament space at the crestal margin, the level and quality of crestal bone. In periodontitis, there is loss of corticated interdental crestal margin and the bone edge becomes irregular and blunted. Check the angle between the crestal bone and the lamina dura. Loss of normal sharp angle between the crestal bone and the lamina dura, the bone angle becomes more rounded and irregular in periodontitis. Also, check the pattern of bone loss, whether it is horizontal or vertical bone loss, and also check for the loss of bone in the furcation areas of the multi-rooted teeth and widening of the interdental periodontal ligament spaces, and check if there are any calculus deposits. Here we can see the normal interdental region. There is vertical bone loss, there is involvement of the furcation, there is horizontal bone loss and presence of radio-opaque deposits or the calculus deposits. So, once we have completed interpreting all the aspects of a tooth, follow the same method for rest of the teeth. Assess the artifacts if any and postulate the radiographic diagnosis. Always remember, the eyes don't see what the mind doesn't know. So, in order to interpret the radiograph, we need to have a good knowledge about the normal anatomic landmarks, the pattern of the bone, morphology of the tooth, and the various diseases affecting the teeth as well as the adjacent alveolar bone. So, only if we have knowledge about the various pathologies affecting, then only we will be able to diagnose these conditions. Let's interpret this radiograph now. Here is a radiograph belonging to mandibular left back tooth region. The teeth that we can see here are partially seen 3-5, then here is a 3-6, then 3-7 and 3-8. Let's consider 3-6 as the tooth of interest. So, according to what I have already mentioned, first we have to interpret the crown part or the coronal part. Here you can see the entire coronal part is covered by radio-opaque structure suggestive of a metallic crown. Then in the radicular part, look at the outline of the root. The root appears to be normal, and the pulp canal, you can see radio opacity along the pulp canal suggestive of obturated tooth or a root canal filling material. Now let us analyze the periapical region. Periapically, here we are able to trace the lamina dura, whereas here you can clearly see there is loss of continuity of the lamina dura at this part, and there is a hazy radiolucency which is ill defined and suggestive of rarefying osteitis or clinically periapical abscess. Next, look at the interdental bone region. The bone has adequate height when compared to the cemento-enamel junction of the tooth. Once we are done with the tooth of interest, next let us analyze the adjacent tooth. In 3-7, we can see in the coronal part there is a well-defined radio opacity suggestive of a restoration present on the occlusal surface of the tooth. Radicularly, it appears normal, and periapically also there is lamina dura as well as the PDL space. Interdentally, it appears normal, and the partially seen teeth are 3-8 and 3-5. Now, considering the 3-8, we can see radiolucency on the mesial aspect of 3-8, which is an ill-defined radiolucency suggestive of a dental caries. And in 3-5, we can see well-defined radio opacity suggestive of restoration. Now, while postulating the radiographic diagnosis, first we will give diagnosis for the tooth of interest, that is rarefying osteitis in relation to 3-6, then restoration seen in relation to 3-7 and 3-5, and a dentinal caries seen on the mesial aspect of 3-8. With this, we come to the end of this presentation. Thank you.